Alright, hi guys, this is a review of Pharm for Neuro, lecture 4950. We're looking at drugs for Parkinson's and then antipsychotics, ADHD, sleep disorder overall, but a lot of talking about dopamine in particular. So just starting with, dopamine, we know it acts as a neuromodulator, so it's a neurotransmitter that serves as a neuromodulator via effect on our G-coupled protein receptors, the metabotropic receptors, metabotropic or G-coupled protein receptors. And so dopamine and or its receptors are good targets for treatment of Parkinson's disease, schizophrenia, psychotic disorders, ADHD, excessive sleepiness, and then other central nervous system disorders. Dopamine and or its receptors, these treatment of these diseases makes up 1 out of every 6 central nervous system prescriptions. But overall, dopamine is a catecholamine neurotransmitter. It can be converted into neuroepinephrine or epinephrine, and we can see that here we have tyrosine, and in this rate limiting step, we have tyrosine being converted into uh, dihydroxyphenylalanine, and then that will be converted into dopamine by aromatic amino acid decarboxylase, and then tyrosine to this dihydroxyphenylalanine is done by tyrosine hydroxylase. So tyrosine hydroxylase and then aromatic amino acid decarboxylase to get ultimately to dopamine. All right, so dopamine gets stored in vesicles via the vesicular monoamine transporter 2, which we abbreviate as VMAT. It uses a protein gradient from ATPase, protein, again, H+, so H+ gradient from ATPase to send dopamine into a vesicle. And then on depolarization of a neuron, dopamine is going to leave the cell slash vesicles and go into the synaptic cleft, which you can see here. So here's dopamine being transported into a vesicle by VMAT with this proton gradient. And then we have the vesicle fusing with the end of the axon and dopamine going into the synapse where it will act on the dopamine receptors, of which we have a couple of different types. Dopamine is reuptaken by the dopamine transporter, and it co-transports with sodium ions, and then it can get converted into homovinylic acid by monoamine oxidase, the famous MAO, which we've seen in many lectures. So dopamine to ultimately homovinylic acid. You can also have this step occur via catecholamine O-methyl transferase, which is COMT as its abbreviation, which you can see that guy here. Okay, so dopamine can be broken down into waste products, but overall, just we're looking at dopamine as potential usage for Parkinson's, schizophrenia, psychotic disorders, ADHD, excessive sleepiness. Because dopamine is catecholamine and it's originating from tyrosine, well, we have neuroepinephrine also originates from tyrosine, so neuroepinephrine is derived from dopamine, and then serotonin is another neurotransmitter. It's derived from another amino acid, but not tyrosine like dopamine, but it is similar overall as a neurotransmitter. So basically, because it's similar, serotonin and neuroepinephrine to dopamine, the drugs that affect the dopamine processes can affect the same processes in neurons that use serotonin or neuroepi. And this, as a result, there's an overlapping modulatory effect on brain function. Generally, these 3 are used by neurons that are based in the midbrain or brainstem, but overall, those neurons are going to innervate large areas of the forebrain in particular. So just knowing dopamine, similar to neuroepi, similar to serotonin. All right, so we mentioned something about dopamine receptors. There's 5 different dopamine receptors. We only really care about D1 and D2 for our classes. So D1 is excitatory, and this is going to be, we're going to see this in our basal ganglia lectures for neuro. It's excitatory. D2 is inhibitory. Also, you can see in basal ganglia lectures, but D1 versus D2, striatum, substantia nigra. So when we talk about basal ganglia, which is modulating movement, and so dopamine is a neuromodulator, it makes sense that dopamine in the basal ganglia would be involved. In fact, Parkinson's has to do with the destruction of the substantia nigra, which is the primary producer of dopamine overall. So, hold on a second. All right, I need a little bit of water. All right, so central dopamine pathways. Most clinically relevant is, as we said, in the midbrain, the substantia nigra of the basal ganglia and the adjacent ventral tegmental area. This is going to send widespread innervations to the forebrain, and you can see that here, such as the cortex to help with cognition. We know that the frontal lobe is doing executive function. Limbic area is like right here and here, which helps regulate emotion, goal-directed thinking, affect / mood, and then reward overall. And then basal ganglia is modulating movement overall. So dopamine neurons are also helping in the hypothalamus, which is our master regulator, right? It's doing all the different functions to control the endocrine system. And then the autonomic nervous system, so helping regulate hormones, and dopamine in particular is helping with prolactin and growth hormone. But specifically, unfortunately, we don't have drugs that specifically affect dopamine in just one system. You need to be able to predict the side effects because dopamine gets used in more than one place. All right, so Parkinson's disease is something that we'll talk about in neuro anatomy in particular, but in particular we have the basal ganglia, and you have the substantia nigra of the basal ganglia, which is this dark region, named that because it is in fact dark. And notice this is non-Parkinson's. Substantia nigra is dark because dopamine can be converted into melanin, right, that pigment. And so if you have a midbrain that looks a little bit like this, you can see that there's less dark area right here. We've lost some of the dopamine producing cells. So Parkinson's, stooped posture, back rigidity, flexed elbows, tremors in the legs, hand tremor, poorly modulated movements, poorly controlled movements, and this is believed to be as a result of the loss of dopamine in particular. So dopamine is robustly expressed in the basal ganglia, which is region involved in the motor control. So right here, we're seeing the most caudal part of the basal ganglia, the substantia nigra, and loss of the dopamine cells of the basal ganglia underlies Parkinson's. If you want to treat Parkinson's, the treatment goal is to boost dopamine levels or to boost dopamine's signaling. And so We have L-Dopa as a drug, which is converted to dopamine in the central nervous system, especially when it's used with carbidopa, which is a peripheral inhibitor of L-Dopa to dopamine. So we can convert more of it into dopamine in the central nervous system. But L-Dopa is reserved for when other dopamine meds are not effective. Then you have the COMT inhibitors. Remember, COMT, in addition to MAO, both break down dopamine into waste products. COMT in particular is used in the peripheral nervous system, and the drug that will inhibit the breakdown of dopamine acting on these COMT inhibitors is Capone, and I mispronounced that, I'm sure. But then we have MAO inhibitors. MAO also converts dopamine to waste products in the central nervous system, and MAO inhibitor is Cell-Gilene. And then you have dopamine receptor agonists, so act on the receptors to increase the signaling of dopamine. And you have ropinirole and pramipexole, and these are going to activate the dopamine receptors. So overall here, we had this on the previous page, but L-Dopa converted to dopamine. We have our dopamine receptors you can act on. MAO is converting dopamine into waste products, as is COMT converting it into waste products. So those are all good targets. And we have, so these drugs that are used for Parkinson's disease, ropinirole is the most common, and we said that's a dopamine receptor agonist. Then our second most common is pramipexole, and pramipexole also does the same thing, dopamine receptor agonist. And then finally, our carbidopa and levodopa are the next most common. Carbidopa is working with L-Dopa to ensure that you have a higher level of dopamine in the central nervous system. So that's Parkinson's. Basically, work on making sure you have more dopamine, because the underlying mechanism of the disease is destruction of the dopamine producing cells in the basal ganglia. So then you have schizophrenia, and schizophrenia, you guys I'm sure are familiar with, debilitating psychotic disorder characterized by delusions, hallucinations, thought disorders, apathy, emotional blunting. And the idea is that dopamine releasing drugs such as amphetamines can exacerbate schizophrenic symptoms. That is not good. And then all effective antipsychotic drugs are dopamine 2 receptor antagonists, so keep dopamine signaling from occurring in schizophrenia treatment. And the exception is aripiprazole, which is a weak partial dopamine 2 receptor agonist. So it's a little strange. Newer second generation antipsychotic drugs include quetiapine, aripiprazole, and risperidone. They interact with monoamine receptors in addition to dopamine 2 receptors. And so that's meant to decrease dopamine overall. So blocking of dopamine receptors is a good thing for our antipsychotics. But generic antipsychotics, we have haloperidol, it's older generation, and then we have clozapine, antipsychotic drug with unique efficacy in treatment-resistant cases, but has a high toxicity. And then side effects of blocking dopamine receptors in the basal ganglia can cause movement disorders that are Parkinson's-like. So basically, treatment of schizophrenia is exact opposite to the treatment of Parkinson's. You want to have less effective dopamine in schizophrenia, more effective dopamine in Parkinson's. All right, so then we said amphetamines are dopamine-releasing drugs. And so we don't use amphetamines in schizophrenia, but we could use them elsewhere. And so in particular, ADHD, we have dopamine being used. And so dopamine enhancing drugs such as these amphetamines, it's one of the treatments of choice for ADHD. The idea is that it enters the cell via dopamine transport, DAT. It will access these dopamine-filled vesicles via the VMAT2 transport, and then it will cause the release of dopamine into the synapse. And so amphetamines can also inhibit breakdown of dopamine by inhibiting MAO, and it can also cause the dopamine transporter to, instead of taking up dopamine, to reverse and send dopamine out into the synapse, which would be good for the treatment of ADHD. All right, so then we have this drug, methylphenidate, which is increasing dopamine in the synapse by blocking dopamine transport reuptake, mediated reuptake of dopamine. Other effects of amphetamines, so increased alertness, decreased fatigue, suppressed appetite. You can use amphetamines for sleep disorders, narcolepsy, and shift sleep work disorder. And so another sort of stimulant, we have modafinil. It's a new stimulant that appears to work partially through dopamine augmenting mechanism, and just thought on stimulants in general. They're touted as cognitive enhancers, but evidence they just say they help with alertness. So, but overall, dopamine augmenting drugs or amphetamines are 1 out of every 10 central nervous system prescriptions. And again, this is helping with ADHD and sleep disorders or amphetamines. So, dextroamphetamine, amphetamine aspartate, methylphenidate, lisdexamfetamine. Okay. So then we have dopamine in reward mechanisms. So we'll talk about the one second. Right, the reward center of the brain. Later on, specifically in the forebrain, we have the nucleus accumbens. And then when we talk about basal ganglia, we have the caudate putamen, which we together call the striate nucleus of the basal ganglia. But dopamine, in particular, you have drugs of abuse have a common mechanism of action of augmenting dopamine release. And so this reward center is going to be affected. Cocaine in particular directly blocks the dopamine transporter, so increases extracellular dopamine in the synapse between axons. Nicotine, ethanol, or alcohols, marijuana, heroin, all increase the rate of dopamine neuron discharge. And then amphetamines can accumulate in synapses, displace dopamine, and raise extracellular dopamine overall. All right, so not too bad. We see the use of dopamine to help with Parkinson's, the use of dopamine enhancement, or enhancing the amount of dopamine with amphetamines used for ADHD and sleep disorders, and then cocaine is acting on dopamine release, specifically on the reward center of the body nucleus accumbens. So then we have antidepressants is our next topic, which we're getting through stuff. So specifically talking about serotonin. So we have serotonergic neurons, in particular the raphe neuron, or nuclei, excuse me, in the brainstem here. It's a prominently midline cell group extending throughout the brainstem that contain all of the serotonergic neurons in the brain. So the cells that produce serotonin are a neurotransmitter that is similar to dopamine. And so cells that are in the raphe nucleus express this enzyme TPH2, which converts tryptophan, one of our amino acids, into 5-hydroxytryptophan. 5-hydroxytryptophan will be converted into serotonin via the amino acid decarboxylase enzyme. And then serotonin, just like dopamine, is synthesized in the cytoplasm, and it's packaged into vesicles by VMAT. Inside of the serotonergic neurons, inside of the raphe nuclei, or that make up the raphe nuclei, serotonin gets degraded by MAO and aldehyde dehydrogenase to later be keyed out. So serotonin gets released in synaptic clefts after leaving the vesicles. It gets inactivated by diffusion, and then it can be reuptaken into the serotonergic neurons by serotonin transporter, aka SERT. Serotonin receptors, there's 7 classes of them, mostly G-coupled protein, all but one, and then one is ligand-gated. Overall, the serotonin receptors are not limited to serotonin neurons, and serotonin neurons only express 3 out of the 7 types that function as basically receptors will inhibit neuronal activity and then stimulate serotonin release on the neurons that release serotonin. All right, very similar to dopamine, as is the next one, which is neuroepinephrine. And so specifically, serotonin did not come from tyrosine like dopamine came from tryptophan, but very similar in terms of its function. And neuroepinephrine is coming from tyrosine, just like dopamine. So starting with neuroepinephrine, the locus coeruleus is a small nucleus on the edge of the fourth ventricle, located in the pons. It contains most of the neuroepinephrine releasing cells in the brain. Other neuroepinephrine releasing cells are located ventrally and posteriorly in the brain, and these cells project to the entire neural axis and provide the totality of neuroepi and epinephrine innervation at the brain and spinal cord levels. So it being similar to dopamine, neuroepinephrine neurons make dopamine from tyrosine. In particular, these neurons in the locus coeruleus, again in the pons, the edge of the fourth ventricle, they're going to express dopamine beta hydroxylase, which will convert dopamine into neuroepinephrine. And then a small group of cells posterior to the locus coeruleus also express phenylethanolamine and methyltransferase, PNMT, which you may remember from previous lectures. And we have neuroepi gets converted by PNMT into epinephrine. So neuroepinephrine is a catecholamine, and it's mostly synthesized in the cytoplasm, packaged into vesicles by VMAT. In the synaptic cleft, neuroepi and epinephrine are inactivated by diffusion, and its reuptake is done by the neuroepi transporter net. So neuroepi receptors include we have our G-coupled protein receptors, but acting on alpha-1, alpha-2 beta receptors, and they're all metabotropic G-coupled protein receptors. The different types are not distributed evenly, but differentially expressed depending on what region you're in. Neuroepinephrine neurons express themselves will express the alpha-2 receptors, aka autoreceptors, and they function to suppress the activities of these same neurons, inhibit neuroepinephrine release, which kind of makes sense. If you're having, just like the serotonin, where you have autoreceptors are going to inhibit serotonin release because they're like, oh, there's already serotonin now. Neuroepinephrine, if it's released, it's going to bind to itself and say, hey, you've already released neuroepinephrine. Why don't you not release more because we already have some? All right, so then where are we going with this? We're trying to go to treatment of depression and anxiety. And so our first antidepressants were to basically maintain serotonin and neuroepinephrine. So you have 2 main classes. You have MAO inhibitors. Remember, MAO breakdown serotonin and neuroepinephrine. So MAO inhibitors, MAO-Is, our primary drug is iprone-izide. Then we also have tricyclic antidepressants, TCAs, and our primary one is imipramide, and that binds to / inhibits the serotonin reuptake inhibitor and or the neuroepinephrine transporter. So basically maintain the amount of serotonin and neuroepinephrine in the synaptic clefts. And MAO inhibitors are just saying, hey, stop breaking down my serotonin and neuroepinephrine. All right, so then we said imipramide works on the neuroepinephrine transporters, and then you have a serotonin reuptake transporter SERTs. You have another drug, desmapramide, works on neuroepinephrine transporter. Clomipramine is used for OCD, works on SERT, and then amitriptyline is for pain management. Then we have atomexetine, which is a neuroepinephrine transport inhibitor used for ADHD. All right, but the idea is that drugs that block the serotonin reuptake transporters are used for OCD treatment. And then more MAO inhibitors, we already talked about iprone-izide. We also have isocarboxazide, phenylzine, and then selegiline, which we're familiar with. All right, and then we have buspirone, which is a selective agonist of serotonin receptors, so working on the receptor itself to promote the effects of serotonin, and it's effective for generalized anxiety. Then you have SSRIs, which are selective serotonin reuptake inhibitors, again, anxiety and depression, and we have fluoxetine, paroxetine, sertraline, and then S-citalopram. And then we have selective serotonin and neuroepinephrine reuptake inhibitors, SNRIs. We have venlafaxine, duloxetine overall. And then finally, we have a different target. So NMDA receptors are receptors for glycine glutamate. You remember that glutamate is the primary neurotransmitter in the central nervous system, and it's stimulatory or excitatory. Ketamine will block this receptor, and it has an antidepressant effect. So ketamine, antidepressant, but it also has dissociative anesthetic effects with the potential for abuse. But we have S-isomer, S-ketamine is approved as an antidepressant instead of ketamine, but it works on the receptor for glutamate and DMA receptor. All right, finally we have mood stabilizers. So some depression patients exhibit sort of a mania and then a hypomania, aka alternating depressive episodes. So mood stabilizers, we have carbamazepine, and then valproic acid, and then lithium. All right, so just a quick summary. First generation antidepressants, tricyclic antidepressants, TCAs, and they're blocking SERT and NET. Then you have monoamine oxidase inhibitors, MAO inhibitors. Then second generation are selective serotonin reuptake inhibitors, and then our serotonin norepinephrine uptake inhibitors. And then drugs used for the treatment of anxiety include just like that, SNRIs, benzodiazepines, buspirone, other antidepressants listed here, antidepressants used in the treatment of pain, SNRIs, duloxetine, and then tricyclic antidepressants, amitriptyline. So tons of words. And I would say, again, this is a case of, we have gone through the theory, and now it is time to actually memorize things. So I would, recommend using Sketchy, and then after you've gone through Sketchy once, do the questions they have, and then end with looking at some Anki for this. And so good luck, guys. I know this has been stressful, and I hope you're all doing well. All right, bye.